Hi, welcome everybody to Supporting Children and Families to Recognise and Navigate Pediatric Anxiety. I'm Vicki Mansfield, Practice Development Officer from Emerging Minds. I'll be facilitating tonight's webinar. So it's great to have you all coming in this evening. Let's just move to our next slide, which Emerging Minds and the Mental Health Professional Network would wish to acknowledge the traditional custodians of the lands across Australia from which our webinar presenters and participants are located. We wish to pay respect to elders past and present and future for the memories, traditions, cultures and hopes of Indigenous Australia. And I'm meeting with you all tonight from a Wabakal country, and please feel free to enter into the chat the country which you're meeting. It's great to see how far and wide we are for this evening. So this is our second webinar in the 5th series on infant and child mental health, which has been presented by Emerging Minds and the Mental Health Professionals Network. And there's a few more webinars coming up in this series. Later this year in November, we'll have Working with Children with Higher Weight. And then early next year, Supporting Children who've disclosed trauma, First Nations children and experiencing family violence and bullying. So lots of great webinars to come up after Christmas. And you can subscribe at our emergingminds.com or at the MHPN portal. So the learning outcomes you will have seen when you registered, so I won't go through them all this evening. You can access them on the information button, but it's certainly, giving us a range of ideas around managing anxiety and looking from a multidisciplinary perspective. And we'll go to the next one. And so our panel tonight has a really rich depth of experience and knowledge in this area. So it's very exciting to be able to meet our panellists. And they'll be talking about the case study of Lucy. And Lucy is 5 years old and lives with Jane, Patrick, her parents, her older brother, Tom. And she's struggled with some tummy pains, often doesn't want to go to school. It's very emotional at home at times. So our panellists will be talking about Lucy. But before we launch into talking about Lucy, I'll just check in and introduce each of our panellists. So first I would like to welcome Dr. Andrew Leech, who's a general practitioner from WA. So welcome, Andrew.
Thanks, Vicki. Thanks for having me.
Andrew, you're a strong advocate for child mental health, and I understand that you've recently set up a new practice which you kept kids in mind when you were even looking at that. So what's your favourite child-friendly piece of the practice?
Yeah, I sort of thought it's really important to try and help kids feel comfortable in the healthcare space, and did a lot of research around some of the kids' hospitals, in Australia and overseas, and brought some of those bits and pieces into the clinic, including the room you see here with the really colourful, bright sort of environment. And I think, to be honest, my favourite space is the interactive screens at the front where we have a set of games. So I'm often caught up there playing games myself. And in fact, we have kids that, don't want to leave after they've come to the doctor, which is great. I mean, it's not ideal, but it's good that they have a sort of a positive experience coming into this sort of space. So, that's probably my favourite part of the clinic.
Yeah, absolutely. And it's so lovely to feel like it's child friendly, because it certainly may not have been the experience, certainly when I was growing up. And then I'd love to introduce Rachel Tomlinson, who's a psychologist from WA. Welcome, Rachel.
Thank you.
Rachel, it's lovely to have you here this evening, and I look forward to hearing your presentation tonight. But I also know, Rachel, that you have a delightful children's book that I read this year. It's called A Blue Kind of Day, and it's beautifully illustrated, so it's a lovely book. But I wondered how useful and important are books in your work with children?
Thank you for your kind words. I think for me, the book came up because I had parents asking for, where is more information? How can I introduce a tricky topic or concept to my child? And we're finding more and more therapeutic texts. Not that a text has to be therapeutic to be beneficial, but I think that there's something that's really important is that all children should be able to see themselves represented in some way in literature. So the children that come to see us live complicated lives, and it's really important that they can see other children living and experiencing that. Gives them a frame of reference. It also gives them, a sense of coping and hope and resilience. And it also helps us to really be able to introduce, as I said, quite gently, some more complicated or challenging topics. And even if a child isn't participating in that kind of thing, it can build their empathy for others with those same experiences.
Fantastic. Thank you, Rachel. And I'll then move to Dr. Ros Powrie. Ros is a child and adolescent psychiatrist in South Australia. Welcome, Ros. You're just off mute, Ros. Oh, back on.
Thanks, Vicki, and welcome from Ghana country.
Lovely to have you with us. And Ros, I know you're also a trainer and educator in mindfulness-based childbirth and parenting. And I'm wondering, do you see this as a health promotion, early prevention for children's mental health?
That's exactly what it is, Vicki. I started earlier in my career at the other end, seeing difficult adolescents who had problems that I think started very early in life. And I'm a very strong advocate for advocating for our resources to be at the upstream rather than the downstream end of life, because that's where I think we can create greatest intergenerational change. And this is my small contribution and something I find is very rewarding.
Fantastic. And I think that early end is such a fantastic place to support families and children. So thank you all for introducing yourselves briefly tonight. And so I will let us move towards chatting about Lucy. So I'll start with inviting Andrew, if you'd like to give your perspective from the general practice perspective.
Sure. Yeah, thanks, Vicki. We'll go on to the next slide just to get started. So Lucy, I think, is a really typical patient for GPs, but not just GPs, for all of us as health professionals. I think we see Lucy, 5-year-old girl with high anxiety, going through a difficult time on a very regular basis. So it's something we'll be familiar with, but not always have the answers for. And it can become very complicated and tricky very early on. And we're seeing some of those symptoms develop now in Lucy, who is having a tricky time. I think the first point I wanted to make was just remembering that Lucy is the patient. She's the child that's presenting to us with these difficulties, and to not forget that. And it's very easy in our fast-paced consults in general practice especially to sort of mainly engage with the parents, and Lucy sits in the chair further down and we can't see her even, or she's too shy or scared to even be there. So having that engagement with the child and building that rapport early goes a long way to getting the information you need later. Next slide. In talking to parents, I often ask them, what is it I can help you with today? What do you think would be the biggest help? And it's amazing. A lot of parents are just looking for someone to listen to them, someone to hear their story and to understand them They often say, well, I've been between lots of different people, but I feel like I'm not getting my point across. So we need to find out, what is that point? What is that concern they're having? And I do that by recapping. I'm saying, so what you're telling me today is this about Lucy. Is this what you're saying? But I'll also go one further and then talk to Lucy as well and say, is that true what Mum's saying? Is that what you're feeling as well? Are they some of the things you're going through? And check in with the child, and that's how we involve her in the process. Those consults are typically short, so often booked in for a short session, and we need to follow them up. Next slide. And this is that typical iceberg sort of picture where what we're seeing is not what actually is happening. It's far deeper than that. It's underneath the water, underneath the surface. We're seeing a child that might be told off at school, who's getting in trouble, told that they're naughty, which affects their self-esteem. They might have tummy aches, which means they're missing school because mum thinks they're sick all the time, getting headaches. So a lot of those physical symptoms in children, which is a little bit different to how adults might experience anxiety. Even difficulty concentrating. A classic one is a parent coming in thinking, oh, is my child got ADHD? They're not listening, they're not concentrating. But hang on a second, are they anxious? Are they actually having trouble because they've got anxiety? So we've got to think about anxiety really broadly first before we narrow it down and think about those physical symptoms. Next slide. And the really important thing that I love telling parents is anxiety is a normal emotion. And I love telling kids this as well. We all feel anxiety. I even sometimes give examples of when I've had anxiety and stress and fear and nightmares. And these are normal life experiences, and life would be pretty boring without anxiety. So there are age-related anxieties and developmentally normal anxieties, and those social skill problems at school particularly can be quite normal in that primary school year. Fear of losing a loved one. And in Lucy's case, she might be really scared that mum's going to die, and she's got dad doing FIFO work, and she's going to be left all alone. And that's actually quite a classic answer from a child that is struggling to go to school. I'm scared I'm going to be all alone. So, just delving deeper and realizing that these can be normal experiences, but if it's impacting their life and really impacting the way they behave and impacting their well-being, that's when we need to tune in a bit more and help them. Next slide. So I might use the word anxiety, but I also like to use other words just to make it age-related. So being scared or having a worry, having a tummy ache or butterflies. So just being mindful of the language I'm using in front of a child. I try not to let them think that there's something wrong with them. Try to make them think that it's actually, it's a feeling, a thought, or an emotion. It's part of life, but it's important that they do learn to verbalize it and they do learn to express themselves. Another way that can be helpful is using an objective measure. So rating the worry from 0 to 10, getting them to say, where they sit on that scale, and then document that and come back to it next time. So I can sort of keep it a bit of a measure of how they're going. Next slide. And that's what we were saying. So normalizing anxious feelings. So bringing it out into the open in this safe space, in a general practice or in a psychology office or in a pediatrician or psychiatrist office, bringing out those emotions, or even just at home in bed, being able to normalize and express ourselves is so powerful. In fact, that's therapeutic on its own for children to be able to come in and speak about what's going on. So it's not bottled up like a big pressure cooker inside anymore. Next slide. I just made up this acronym. I thought there's got to be a way to put all these things together. But these are the things I love to get out in that first or second consult when you've got that 30-minute follow-up. It's really important to think about these when we're dealing with a child with emotional regulation difficulties or anxiety or just coming in with complex issues. I find these are some of the core areas that we in general practice can help with. And simple tweaks to many of these areas can go a huge long way before we've even involved anyone else. So, and it's almost in order of what I would ask, how do we help this child become stronger? Sleep, definitely asking about sleep. Television and screen time, and letting parents know a little bit about what the national guidelines are around screen time. For a 5-year-old, it's only 1 hour of screen time a day, and I know my 5-year-old is definitely not getting 1 hour a day. It's very hard to stick to, but sometimes that just little surprise for parents, can help them to realize, oh, okay, maybe I need to rein that in a little bit. Relationships with others, their friends, their family, anything medical that could be going on. occasionally do blood tests or do a full physical examination, have a look at their ears, their throat, make sure they're hearing things well, make sure their heart, lungs, everything sounds okay. That's really important as well for a GP. We have to think really broadly. Diet, so important. I could spend 20 minutes talking about nutrition. The amount of times I've heard Fruit Loops for breakfast is quite funny. It's very popular breakfast, but is that actually the nutrition they need before they go to school? Games, what makes them buzz? What gives them purpose in life? I try and encourage them to join a sport or join an activity, school and routines. Next slide. And so based on all those questions, what are some of those tweaks that we can provide in general practice before we start to think about anxiety as a whole? And how can we improve this anxiety really quickly? We can hand out things to parents. We could talk about mindfulness, talk about the Smiling Mind app, and let parents know it's okay to have 5 minutes at the end of the day to stop and just spend some time together quietly, playing a card game, playing a board game, reading a book. These are really important, precious moments that the child is having with the family. Cutting down the screen time, talking a bit about diet, but I'm never doing that with judgment. We're all human, and we do our best, and that's okay. The best is okay, but just being careful with some of the sugary foods that might link to hyperactivity and then anxiety as well. And sleep hygiene, really trying to get that sleep better if possible, if it's not going well. And just calming the whole household down. Are we doing too much in our house? Have we got too much on the go at once? Is there anything we can take off? Or can we give mum and dad some time out, give them a med cert so they can have a couple of weeks off to just let things settle a little bit to try and help work through some of these things. Next slide. And just to finish, a couple of the objective screens I might use, I'll hand out to the parents before they go. The Spence anxiety score or the strengths and difficulties questionnaire is a really good one because that matches the age Lucy is. So give that to them to come and bring that back to me and consider if this is impacting school, learning and home life. Do we need a mental health care plan? Do we need the help of an OT or psychologist? And particularly in the young kids, I love using the OTs. The mental health OTs have lots of fun games that kids enjoy to try and help them with that emotional regulation. Thank you.
Thanks so much, Andrew. And I think, I really loved that stronger acronym. There's so much in that. And also the iceberg, the tip of the iceberg and what's underneath. So I think there's some really great messages there. And so I'll invite Rachel. Often it's not uncommon that maybe a GP may refer on, and Rachel, it'd be great to hear from your perspective. Welcome back again.
Thank you. If you can, perfect. I was just going to say next slide and I got beaten to it. So when I'm first starting to work with a child and their family, as a psychologist, I often require a secondary consult. I'm not going to get all of the necessary information from the child. So I might need to consider who I would speak to. Primarily, it would be parents, but it may also be schools as well. I'd definitely start by looking at diagnostic criteria. So I've popped here, the DSM, that's the key, diagnostic tool that I would be considering. And not that we always need a diagnosis, but if we're matching some of those diagnostic criteria as a psychologist, it then helps me to better match to evidence-based treatments. So looking at Lucy's presentation, she absolutely meets the criteria for generalized anxiety disorder. And there's also the potential of comorbidity here with social anxiety disorder or social phobia. This is partly met, so I'd need further information and discussion with the family to identify where the origin comes from. So the fear of action, presence of symptoms, being negatively evaluated. We're not quite sure with this information just yet. So it could be an emerging diagnosis, and this will really build into my treatment planning. So also just reiterating Andrew's point about how children's presentations would differ in ways that we might check off kind of criteria or diagnostic symptoms with adults. They often present with more psychosomatic symptoms. So things like tummy upsets, headaches, things like that. They wouldn't necessarily say, I'm feeling anxious with those words. Next slide. So the next step is thinking about reviewing a child's behaviour. It should never be reviewed in isolation. So we really look in depth at the biopsychosocial model. And I know that Roz is going to cover some of this, so I'm not going to review it too much. It's there for you to read. I know that you'll all get the slide packs. These are the things that I would personally be sort of wanting to tease out, not just in the initial assessment, but ongoing, how the family responds and relates to these particular domains, relational, developmental, and psychosocial. One of the key things, and this is from a psychological perspective, but also personally, looking at this as an area of interest in children, is the vulnerabilities around transitions. So we see key behavioural challenges for Lucy associated with her transitions to school and also returning home from school. These are key points where mum is really struggling and where Lucy's behaviour indicates that she's really struggling as well. So we know in general that transitions are tricky for children, but anxiety also really exacerbates that. So this would really feed heavily into my treatment planning and how I would be working with Lucy and her family. Next slide. So Andrew covered this very succinctly and very nicely. So I'm going to be mindful not to repeat too much of this, but just agreeing with, when we work with families, it has to be that strengths-based approach, figuring out what they're doing already and what they're doing well. We want to create allies. We need the parents. The parents are often the gatekeepers for the children. Children can't drive themselves to appointments or facilitate their own referrals. So we really need to be working closely with families and ensuring that our language is non-judgmental. And parents are also really keen for practical skills. Theory is nice and psychoeducation is very important, but they want a lot of takeaways. They're really struggling. They've probably struggled for a while before they've reached out to you for support. So giving them something very tangible to take away is going to help to build that confidence and help to create that buy-in really quickly that this is effective. I'm going to keep coming back and supporting my child in this process. So some of those really practical things that Andrew mentioned, and in my next slide, which we're not going to the next slide yet, but in the next slide, I'll cover some of those practical tips. But for me, goal setting in the primary, so in the intake and also reviewing as we go in these sessions is really, really important. So not only goals of the parent, but also goals of the child. What are they struggling with? How would they like things to look different so that we've got a really, really tangible outcome in mind and something to work towards. So next slide. This is my bread and butter. This is why Panellists come back, is the practical stuff. As I said, they really, really want these tools and these tips. So when I'm working with a child with anxiety, evidence-based indicates that a modified or parental supported CBT approach is incredibly effective in managing anxiety. So the kinds of things we'd be looking at is exploring reality testing, so putting their detective hats on, identifying faulty or unhelpful thinking patterns, testing that against reality, finding evidence of coping. Andrew mentioned rating scales, so I won't review that one any further. Coping statements, affirmations, gratitudes, having a look at how the child can start to change that internal self-talk about coping and capacity. And then we're also looking at an exposure method, so exposure to triggering situations or circumstances, and then emotional regulation strategies coupled with that. So we're looking at arousal reduction when we're doing these exposure activities. Then we also need to work on increasing the child's emotional intelligence, because we know that relates directly to increased emotional regulation skills and capacity. So there's, lots of different activities out there. So feelings in my body, sort of doing some pictures and getting them to color code areas in their body that matches to different feelings, to help them to make that body-mind connection, a body thermometer or anger thermometer. So how do they tell when they're escalating so that you can then match escalation points to coping strategies, emotions bingo to get them learning about different emotions, reading thematic books that we already discussed. Next slide. And then you've got emotional regulation and arousal reduction strategies. So they're children, so you might give some of the science to the parents about different relaxation breathing. But to teach a child, you would teach them, say, bubble breathing or hot cocoa breathing, teaching them how to use progressive or do progressive muscle relaxation strategies. It could even be developing a sensory box, so looking at their sensory diet and ways to kind of self-regulate and manage. And then some practical skills building for those transitions. I'm pretty aware there's some questions about transitions, so I won't cover this too much, but filling their cups, the 5-cup philosophy of mastery, safety, freedom, connection, and fun. Are their cups filled? Increases their resilience and capacity, reduction in arousal, looking at routines, and that visual or audio cues to prepare them for transition. So that's all for me for now. Thank you.
Thank you, Rachel. And I think the bubble breathing takes me back to my clinical days in mental health social work. all the fun, creative things that we need to engage children. So thanks so much, Rachel.
Thank you.
And so I'll hand over to Dr. Ros Powrie, and she'll present her perspective from a child psychiatrist view. Thanks, Ros.
Thank you, Vicki. And thank you, Andrew and Rachel, because usually by the time a young child's referred to a child psychiatrist, they've probably seen their GP and he's or she has done sensible things, like Andrew mentioned, and they've probably seen a psychologist as well. And somehow things aren't working. Sometimes a child psychiatrist has asked for a second opinion or an opinion about what else might help this child because the standard approaches aren't working. So we usually deal with children where there's some complexity or there's some stuckness in progress with treatment. And so I always go back to what Rachel's already mentioned, trying to understand Lucy and her family in front of me. And so always looking at the biopsychosocial formulation. And I also use that term relational because for young children, relationships are incredibly powerful and important in forming their view of the world and in informing how they cope with changes or difficulties or challenges. So I really want to come to a shared understanding with the parents and Lucy about how come she is experiencing them and they are so worried. Usually parents are pretty tired by the time they get to see someone like me. So I want to start a kind of a conversation which will help bridge and create an understanding, because that's going to inform collaborative treatment planning and where we start and with whom. Next slide, thanks. And so as part of the biopsychosocial formulation, we always look at these 4 Ps. What are the predisposing factors? And for Lucy, I mean, she's a little girl who's been bathed in quite a lot of stress in her life, starting from when she was born. And we know that children who are born prematurely have certain potential neurodevelopmental vulnerabilities cognitively and in their motor development. So they're a bit behind the 8 ball to begin with. And the environment of getting to know your baby for parents in that kind of sudden premature birthing a child prematurely creates all sorts of stress for parents as well. So sometimes they don't even feel like they know their baby when they take their baby home. So I'd be wanting to try and understand what that experience was like for both parents and children, and again, validate and normalize, some of the things that they've been struggling with. Often they are missed and glossed over. And also, as Rachel mentioned, this big change in Lucy's life, which is a big precipitating factor, and that is transitioning to school, and how it seems that she coped initially with this okay, and then sort of became overwhelmed over time. So there's a mismatch it seems, between her capacity to cope with that new environment and the learning that goes on there, and her ability physically and neurodevelopmentally to cope with that, perhaps. And the family, how does this family function? We know that there's a bit of to and froing in the family, that in fact, Lucy's living in two families. She's living in a family with her brother and mother for 2 weeks, and then with all of the family for another 2 weeks. So that's something to be interested in and curious about, how she copes with that, and how the family copes with that, and how mum copes with that. So I'd be really interested in drilling down into the milieu of the environment in which Lucy is making this big transition in her life. And there's, as mentioned, lots of things that have gone on in this family, including concerns over Lucy's health in her early years, mum's miscarriages that might have all sensitised the parents to loss and to threat. And I'll talk about this more in the next slide. And of course, we always want to understand what are the protective factors in families. And there are probably quite a number in this family, but as yet, we just don't know too much about that and what other supports they have. Next slide, thanks. So from my perspective, for all young children of this age, I'm really interested in the first 1,000 and 2,000 days of their life, what we call, the time of greatest brain plasticity, because this is a period where all later physical and mental health kind of is in formation, and there are critical things that need to occur in this time frame to set either a resiliency pathway or a vulnerability pathway. And so in this regard, all babies' experiences and young children's experience are mediated by their caregivers, by their parents. And this can be this relationship that is built in that first year of life, which we call the attachment relationship, can be a very powerful buffer against stress. And of course, the attachment system is activated when babies need protection, need soothing, and we all need this. This goes on through our lifespan, that we all require an attachment. We all have attachment systems that we go to or we create or are created in our close and intimate relationships, even as adults. And so this attachment security, which generally develops by the end of the first year, if everything goes reasonably well, can be affected by many factors, and particularly in Lucy's life, by being sick, by being vulnerable, by having early respiratory problems, and by how her parents have managed that and who has helped them cross that difficult territory. So parental distress, trauma, enduring stress, parental mental health, and all of these kind of things, including how the parents process and reflect on these experiences and make sense of them, can impact on attachment security. So I'm very focused often on ensuring that these fundamental relationships get an airing, and also try and mend broken relationships, if we want to use that term, or return to recovering foundational security in parent-child relationships. So can I have the next slide, please? And I'm putting this up because some of you might have heard of this really neat template for helping parents to understand young children's needs and across the developmental lifespan, called the Circle of Security. And this is sometimes something I often use, or I might refer parents to do a Circle of Security course. It's called COSP, although the original Circle of Security was a much longer therapeutic intervention for vulnerable parents. But sometimes just showing them something like this and saying, look, and noticing in the room with the child how they go out from the secure base to explore their environment and how they come back into the safe haven on the bottom side of that circle on the left-hand side for protection, for comfort. That's when their attachment system is activated, when they need to come in for emotional regulation or comfort. And sometimes just talking to parents about how this works and how it's working in the moment with their child helps the penny to drop, and help them to shift their kind of thinking about how to respond to, say, Lucy's anxiety. And on the other side, this is just a busy diagram that shows what can happen when a child is attending to the parent's needs rather than the parent attending to the child's needs on the left-hand side. That somehow what happens, and maybe this is happening for Lucy, maybe not, that in mum's worry about her child's vulnerability and her exposure to COVID, or early on, even in the nursery situation, or taking her baby home and knowing that her lungs aren't fully mature, that she has not been able to let, in a sense, her child or Lucy go out and kind of explore the environment fully. There's just been that hesitation on her part, which Lucy may have picked up and therefore want to stay in close to mum. So next slide, please. So from my perspective, I always want to think about supporting recovery and particularly relational security, as well as in anxious children, as well as, working on specific targeted symptoms, and always with a collaborative relationship with the parents and the child, and enlisting the parents, helping to know that they are very powerful supports for their child, and they can act as coaches in the kind of whole therapy system, and help them to understand their sphere of influence rather than feeling they have to control things. Because really, do we really have control over anything except our own responses to what's happening around us? I think there are some wonderful ways of talking about fears, as Rachel and Andrew have already mentioned. One of the ways I talk about it is from narrative therapy, where we externalize the problem and talk about standing up to the fear. The problem is the problem, it's not the child. So I think if parents can be on board with that, and Lucy can be on board with that, it's them all standing up to the fear. It's just not Lucy. And 5-year-olds and young children often come up with really incredibly interesting and imaginative ways of standing up to their fears or fighting fears. And that can mean that this can be a really enjoyable and fun kind of treatment setting. It's not heavy, it's not difficult. I take my lead often from what children are telling me and what words they use to describe what they're challenged by. Really important to have to celebrate small wins, because that builds in positive reinforcement, confidence and optimism. Even small changes can make a big difference if they are focused on rather than when the problem arises. And of course, it's really important to address any adult concerns or mental health issues. Really important for parents to develop self-care, because often this is neglected when their focus is on their struggling child. And also not to discount wider supports in family and community, and make good use of those. And if psychological help is needed individually, for parents to help them to find it and support them in that endeavour. So thank you. I'll finish.
Thank you, Roz. There's such a depth of knowledge there, and there's quite a few questions popping through there, but one that was standing out, which I think you were just referencing then, was that, play and playfulness can be a really central part, because there was a question around, is play therapy or, play an important part? But it sounds, from your perspective, that's certainly a significant aspect of engagement, but also can be part of the therapeutic process as well. So thank you, Rachel, Roz and Andrew, for sharing your perspective. There's such a great range. And again, as I said, the different perspectives, it's really useful to have from each person's role. So we do have some questions. Sorry, I just spoke a whole lot on mute. I pressed it, but it didn't come up. So my apologies. It's a bit like a Humphrey B. Bear talking, nothing being heard, though, if you're old enough to know who Humphrey B. Bear is in New South Wales. So, yeah, thank you for your presentations and such a depth of information. So we have pre-registration questions, and we also have some questions coming through on the chat, which you're more than welcome to keep sending through. To start with, there was quite a significant number in this theme. And so I'll ask Andrew, a lot of the audience are interested on the impact of COVID and natural disasters and whether this is causing an increase in childhood anxiety, separation anxiety, school refusal. And I know we talked about normative fears with germs and natural events being part of the normative fears, but I'm wondering if in your experience at the moment, if you're seeing more in presentations and how you're managing that.
I would say yes. I'd say across the board, I'm seeing an increase in mental health presentations in children. I think anxiety is one of the largest proportions of those presentations. And I think it was on that trajectory anyway before COVID came along. When COVID came along, I think it really triggered off certain situations in certain families. You know, some families found it really hard to be at home together and isolate, and that then it caused a high anxiety in the family itself and the child. Others coped very well and enjoyed the time together. It's very dependent on each individual situation. And I see that in the child as well. Some children are resilient and thrived, you know, during their challenging times, and others really struggled. So, but just as a general statement, anxiety, you know, it's one of the biggest mental health problems I'm seeing in practice. And how am I handling that? I'm finding it challenging. I'm finding it at times even overwhelming myself. It's a lot to take on and hear these stories. They're challenging stories. They're tough stories. But, you know, I think like I said in my talk, just bringing it back to basics, looking at that child's world, understanding where this is coming from, what has been the trigger or trauma, such as in a natural disaster or a COVID situation, what has been the thing that's tipped them over the edge into this anxiety state, and how can we help them to understand that anxiety, and how can we help them to regulate and learn to turn down that flight or fight response. So there's some of the things I'm seeing.
Thanks, Andrew. And I think, you know, what you mentioned there, that helping turn down the fight and flight response. And I know one of the other questions, and you mentioned it earlier, Rachel, was that transitioning to and from school and some supports around the strategies for that. And yeah, I'm wondering, in terms of those, is there any other strategies or suggestions? Because there was a lot of interest around, not even just an individual help for this one child, but maybe, you know, even a broader approach of how could classes maybe be helping kind of steady themselves in terms of, children may be feeling anxious in that transition space.
Absolutely. So we understand that there's the wider level of commencing school, but then there's also the daily transition of home to school, school to home. And even then within the school day, we see transitions between classes or subjects, between classes and recess, and then from recess back to classes. So transitions are something that our children do need a significant amount of support with, because it's things that are out of their control and change. And until they know what to expect, it can become quite triggering and distressing for them. So something that I would be sort of talking to, you know, specifically with Lucy's family, but also in a general sense, would be things like having a transition object. So do they have something that they can transition across a number of domains that's like a comfort, or sometimes I call it like a talisman. So it could be, you know, how they've got like fidget spinners, or they've got, there might be like squeeze balls, or like there's some like jewelry, like chewable jewelry or spinning jewelry, something that they will use to help them cope, that they can use to transition between different domains. Then can we put a routine in place? And this can often, particularly for the younger kids, but children with anxiety, it also works better if we have visual cues that mark routine or steps that a child can expect. When our brain knows what to expect, it's much easier for us to feel calm and secure because we know what's happening next. So can we use like pictorial displays, like in the classroom or outside of the classroom? Is there like a wider or broader kind of calendar that we can use to get children sort of thinking about what's coming next to prepare themselves? Also arousal reduction strategies in the lead up to these key points. So can we do some mindfulness? Can we do some grounding or calming? So we want to think about mindfulness and grounding because it stops the brain from going off into future worries or, you know, in the past, this bad thing happened and ruminating about that, and instead getting them to sort of remain in the present where they are actually safe, they are okay, they're not in the past or in the space where something terrible has happened. So identifying sort of those like key times and sort of reducing, as I said, some of that physical overwhelm.
Thanks, Rachel. And I think it's it's a big thing, that separating sometimes both for parent and for child. And I know one of the questions that are coming through on the chat, which is a little broader than that specifically, but I think it was Suzette and Mia were asking around family vulnerabilities. And so, you know, is it the importance, and Ros and Andrew, you may have a perspective, the importance of screening around for trauma or domestic violence, but also supporting the family vulnerabilities in terms of, you know, the mental health. I know you mentioned as well, Ros, the self-care, etc. So, I'm wondering if Ros, you want to speak to that, and then Andrew, if you have, from your perspective as well.
Yeah, I just want to say that so often parents are so focused on their child that they relinquish, you know, ideas about looking after themselves, and then, you know, they sort of spiral slowly and then quickly into exhaustion, and sometimes that can lead to anxiety and depression. But parents, you know, just want to make sure that their children are okay and forget about themselves. So that old, metaphor of putting the oxygen mask on yourself first in the aeroplane and then on your child is something I frequently repeat to parents, because coming back to that aspect about children getting their reference point of safety from their parent. If a parent is spiraling out of control or becoming depressed and sad or distressed, children will pick this up. They are very tuned into their parents, and often parents don't realise that until a child says, "Mummy, why are you always so sad?" "Well, what's worrying you, Mummy?" And that comes as quite a shock to some parents, that their children actually notice their fluctuating mood state. So, that's a very important conversation to have with parents when they are dealing with challenging life events. And we talked about the pandemic and natural disasters. I think it's really important. I mean, often communities come together at the point when things are really difficult and they join up, and we all knew that there was as much more connecting up that was happening during the pandemic, because it was absolutely, everyone realised, I think, or most people, and the messages that were being forwarded from public health was ensure that you stay socially connected. Without social connection, we actually wither. We can't survive without each other. And so I think that aspect was really brought to the fore. But now that the pandemic is sort of doing what it's doing, lingering around, sometimes those loss of social connections can then unveil vulnerabilities or delayed effects of natural disasters or pandemics. And we know that the most vulnerable families in natural disasters and in what we've just gone through with COVID-19 are going to be most exposed in those circumstances, because they often rely on the professional contact or the access to social help that keeps them just with their head above water. So really, our most vulnerable families we need to really pay attention to.
And Andrew, I think I'm wondering, as a point of social connection, and there's that suggestion around screening for if there might be violence or domestic violence that's also precipitating the anxiousness for children. I'm wondering if GPs are a point of contact, and is that something you think's pertinent in your role?
Absolutely. I think we have a responsibility to the parents and to their well-being, as well as the child that's presenting. And one of the final points I'll make to the family as they're leaving the room is, I'd like you to book your own appointment to come back. There's often clues, non-verbal clues, that there's more to the story than what meets the eye, that there's actually a lot of significant events going on in this household, and some of those topics are not suitable for discussion in front of a child. So there's different ways I'll approach that with families. I'll ask them either to book their own appointment. In fact, I walk them out to the desk and say, when can I see you? I'd like to see you, both mum and dad, separately. You need your own doctor. And more often than not, they each end up on mental health care plan seeing a psychologist, which is fantastic, because now we're getting support for everyone. But the other thing that can be empowering to parents is, please write down what's going on for you and for your child and what you've observed, and send it in, and that can be therapeutic for them. Write it all down, send it in, and let's have a look and see and talk through it together. Because I know today it's been difficult for you to be able to talk through some of those things.
Yeah, thanks, Andrew. And I think that's really great, great practical strategies for dealing with some of the complexities around there. And so one of the other big themes that come in pre-registration, and I'll ask all panellists, but maybe Roz, it was how to distinguish between childhood anxiety and the possibility of autism spectrum disorder. And quite a few questions within that theme, I'll let you jump in.
Well, my first response to that, how to distinguish it means, my response is it takes further questioning and exploration. It's not a simple, questionnaire necessarily. Anxiety is very common, we're talking about that right now. We're talking about community anxiety, parental anxiety, childhood anxiety. And we've also talked about the context in which anxiety arises. It's really important to understand the context and that anxiety is common. Autism is less common, but we also know that anxiety, it goes along with autistic children and adults simply because they have a different way of relating to the world. It's social and communication difficulties and challenges, although I think now there's more the neurodiverse community are commenting on about what's right with them, and in fact how there's a mismatch between the expectation set up. But anyway, there's no simple answer to that. If a child is, if a parent is worried about a child being having autism, they need a proper and comprehensive assessment done by professionals in the know with autism, but there are screening questionnaires perhaps that their GP or psychologist can start off with, and then that can lead to further assessment or not. It's like a series of gates you go through, I guess.
And Rachel or Andrew, if you have anything you want to add, it sounds like that there's it can be quite a process. It's not a straight linear process either. Sometimes it can be some backwards and forwards. I'm not sure if Andrew or Rachel, you want to add anything there.
Yeah. I'd be really checking in with the parent why they were concerned about autism, because you might be able to provide some psychoeducation without actually having to even go through that diagnostic criteria about, well, tell me why you're concerned, and is this a concern that we can alleviate with information or strategies? Are there some things that we can try to sort of determine is this just they've got some sensory sensitivities, or they can become, overwhelmed and dysregulated, and it's nothing to do with those sensory sensitivities, which we do see commonly in autism. So I'd be wanting to find out more information about why the parent is concerned with that before I jumped into, hey, let's jump in and start this diagnosis, because it is, as Ros was saying, not just a one-stop shop. You often have to get diagnoses from multiple professionals to then have an official diagnosis of autism. So it's quite a process.
Yeah. Thanks, Rachel. And one of the other hot topics, I guess, that comes through, and it's mentioned by Julie, but also in pre-registration, was when and if is medication looked at. So Ros and Andrew, would you like to comment? Yeah.
Andrew, do you want to start first?
I'll start.
From the ground up.
It's a tricky one. One medication that I do consider helpful is melatonin, and I think in a general practice setting, we want to be as safe as we possibly can, and as evidence-based as we can, but yet try and provide some help in times when everything else has failed. So if I've ticked off that list of things that I could have looked at, like sleep hygiene and diet and, the mindfulness, and we've talked to school, we've gone through all those hard steps, and we've liaised with psychology and involved them, I think there are times when anxiety disorders are severe enough to warrant medication. And when I talk to parents, I talk about this in a chemical sense, that sometimes we just need that to help us to continue on with this treatment. It's part of the treatment, but it's not the whole treatment. It's not the golden pill that's going to suddenly wipe everything away. Those stresses are still there, but certainly melatonin for sleep can be very helpful when introduced. In those children who are struggling to fall asleep, and I find that's when it works well. And I'm quite comfortable giving that, and I'd be keen to hear from Ros about your perspective on that as well. And I feel like, it's a fairly safe and benign drug for a short period of time, often just as a reset, even just to get that body clock reset so we're back on track. It can go a long way. In terms of moving up towards the next level, we're probably talking more about SSRI type medications. That's something I'd like to hear from Ros about, but in general practice, we typically don't prescribe SSRIs in children. It's a sort of a bit of a generalization, but we typically don't, because they're indicated for the ages of 18 and above. However, it doesn't mean there haven't been times where I've had to implement it in consultation, maybe with a psychiatrist or a pediatrician, because we haven't been able to access one very quickly, yet we need some help more urgently. So it doesn't really, it's not clear cut, Vicki. It's not an easy question to answer.
Yeah.
But GP should be wary about what they're doing and making sure that they have the backup to support that decision.
Yeah. And what I hear you say, Andrew, and I'll pass to Roz, is that you wanting to kind of look at all bases and ensure a lot of collaboration is gone and thought's gone into it before you step into that realm. And Roz, I'm wondering from your perspective.
Yeah. Well, I go to the evidence and what we know about the risks and benefits of medications in young children, that we basically, as Andrew's right, we don't have evidence that SSRIs or medications that we'd use typically for severe anxiety in adolescents or older and adults. Children aren't little adults, and so we shouldn't think of them like that. They're children, and they're undergoing huge physical, emotional, and developmental changes. And with that thrust of development, there's lots of opportunities to overcome difficulties, and that's what's in children's favour and in our favour when we work with them. And in my experience, medication is mentioned when health professionals, including my own profession, or parents or teachers are feeling overwhelmed and are not fully understanding the causes and conditions that are creating these symptoms in a child. So I go back to trying to really go back to the formulation and understand what's been happening. And anxiety is something that kind of can build over time like a snowball starting at the top of a mountain. As over time it rolls down and just gets bigger and bigger and bigger until it doesn't look like the original thing that started. So, And I also want to say that we're all infected with anxiety at times when situations are overwhelming, and it's very important to step back and reflect on that and have a way of, containing our anxiety, particularly as parents. Parents can get overwhelmed very quickly when they're juggling a lot of things, and other parents are saying, but my child isn't responding like that, or we did this and that worked and it doesn't with their child. There's so much information around at the moment, well, in our times, really, in our information age, that parents can get swamped pretty quickly with contradictory messages, and then say, well, there must be something that can fix this situation. So
go on, sorry. And what I was thinking is that what I can hear in there is that the importance of taking the bigger picture. And certainly, you said children aren't many adults. And I think, from an emerging minds perspective, that whole of child approach is what I can hear you kind of reiterating, is that it's a tool when you've gone through a lot of other tools. And so that bigger picture of the whole of child sounds like it's and we're not dealing with many adults.
No, we're not. And I'd like to quote something from a very famous child psychiatrist, neuroscientist, and trauma expert called Bruce Perry. Something he said years ago: a relationship is more sensitive than a pill. And that is certainly true. Our pills and medicines are quite blunt instruments in terms of down-regulating our nervous systems, or even in the treatment of depression. They work for some people and they work very effectively, but they don't for others. And there's no evidence that for young children, things like medicines like SSRIs are useful, or that the benefits outweigh the risks.
Yeah. Thanks, Roz, and thanks, Andrew. I know that's it's a question that's often asked. That's one that we have to wrestle with. Yeah. So thanks so much for sharing your insights. I think that's I hope that's really valuable to the audience, because I know within my own practice it's a question that's often bandied around amongst colleagues. But I do love that quote about relationships being more sensitive, because I think that the effectiveness of relationships, we can never underestimate that connection.
And I just want to maybe add one more thing, Vicki, and for your audience, that we have powerful pills inside ourselves called oxytocin and dopamine, and we exchange these, as parents and in everyday kind of interactions. We have powerful effects on each other that impact on our whole neuroendocrine system. So we're not without these sort of powerful medicines in ourselves.
Yeah, great. Thank you. So I'm conscious we're nearing the end of our time together. So thank you all so much, Rachel, Andrew, and Roz, for your presentations tonight and for generously answering the questions. And so as a kind of wrap up from each of you, if I can just hear your last word of wisdom for the audience tonight before we finalise with our last messages. So Rachel, I'll start at the top of who I can see. Your take-home word of wisdom for the audience.
I think validating the parent and the child that there is nothing wrong with them. I think that when we go down the label of anxiety, it can come with a whole host of shame or associated beliefs about what they think anxiety means or where it comes from. And a significant amount of the work that I do is stripping back that shame with families. So validating and normalizing their experiences. There's whole books and things written on these topics for children to feel like it's not just them. They're not, damaged in some way, or sometimes they come in saying, am I crazy? I mean, obviously we would never support that kind of language. So for me, that using that relationship that you have with them to really validate and normalize their experience is key.
Thank you, Rachel. Fantastic. Thank you. Roz, your word of wisdom for the parting moment.
I've got 3 words.
Okay.
Anxiety is understandable.
Yeah, thanks. Yeah. Thank you, Roz. And Andrew, words of wisdom.
I think connecting with the family, listening to the family, making sure you spend that time with them. Sit on your hands, don't type notes, just listen, just take in that story, explore with them what's going on, explore with the child what's happening, use child-friendly language, and finally plan, wrap around a team, of help to support that child. Don't do it alone, and follow up the child at appropriate intervals to keep them, to hold them in your care and look after them.
Thank you. And such beautiful sentiments, I think, from the 3 of you. And I'll just, this is a lovely reflection, which is directed to Andrew, but I think is applicable. It's from Nadia. And thank you for the great work you're doing, being attuned to clients. And I think those last 3 messages and families, and providing a holistic family-centered approach. In my experience as a social worker engaging with vulnerable and complex individuals, it's difficult to find a GP. So thank you for that. So I think that's a reflection to all the panelists. Thank you for the understanding, the validation, and the connection that you've shared with us tonight, and your insights. And so we have a few messages just to finish up for the evening. Thank you all once again. And I'll just go to the next slide. So if participants could click on the feedback survey, which is the top right-hand corner of your screen, and provide feedback, that would be fantastic. As I said, helps us plan for the next sessions. Your statement of attendance will be issued within the next 4 to 6 weeks, and the link to the webinar will also go up within the next 4 to 6 weeks again. So that'll be available. And next slide. And so the slides are all available in the information section, and I'll also go up with the webinar. As I said earlier, you can access www.emergingminds.com.au for any future webinars that are coming up, and register it there, and also through the MHPN site as well. Next slide. And this webinar was co-produced by MHPN, who are fantastic in helping coordinate and organise an Emerging Minds for the National Workforce Centre for Child Mental Health project, which is funded under the Australian Government Department of Health and the National Support for Child and Youth Mental Health program. And I think that's the last slide for us. So there's 350 networks, and there's lots of ranges of topics that are broader than child and mental health, but certainly specific to child mental health as well. And you can find your local network on www.mhpn.org.au. Or you can also start your own network. So once again, thanks everybody for this evening, and thank you for the questions that you've come through, and it's been great to have the panellists with us, and we look forward to exploring more topics with you all in the future. Thanks.